So we discussed this a little bit, but I think we should get into greater depth about the issue on how oncology practices continue to experience financial volatility. Let's discuss the cost and payer pressures that affect the office oncologist. And let's start with the economic constraints, a little bit about competitions, the growing administrative burden, pre-authorizations, proliferation of cost, containment, and then also the issue about documentation, which I think is not spoken about enough. How much time oncologists are now spending, did I get everything in my note to meet the level of my charge? So maybe start with you, Jeff.
Sure. In our practice, we have used two different electronic records in an effort to try and improve documentation and make sure we're doing all the right things and increase efficiencies. The first one was with US Oncology. It was a medical record that was designed really thinking of the physician's workflow. It did not improve our efficiency, but neither did it make our efficiency a whole lot worse. And it served a purpose in that it was searchable if the doctor chose to use it the right way, and I think it improved the care that we gave in many circumstances, if for no other reason that you could now read what the doctor had decided he wanted to do. Then we moved to the current system that our hospital uses, and my documentation time increased by about 2 hours every night for the first 6 months. I see probably 2 or 3 fewer patients every day than I saw before, and I spend at least an hour to 2 hours longer documenting what I did.
So Mike, I want to switch this over to you. So I'm going to give you my personal perspective and what I hear. So as an oncologist, I'm supposed to go in the room and be a diagnostician, understand molecular biology, but then I have to become a healthcare economist and make a social decision in addition to the medical decision for that individual patient. Then I have to go out and make sure I document right to justify what should be obvious what I'm doing given the disease I'm taking care of. Is there any way possible to get rid of that administrative burden of level 3, level 4, level 5, and RAC audits and all these other things? And do you really see that as valuable in the system today?
So those are Medicare constructs. I mean, we should be clear about that. The documentation requirements are Medicare constructs. I can't imagine that you're being audited by your commercial payers for your E&M coding, but maybe I'm wrong about that. We certainly never were when I was in practice. There were some payers that down-coded visits on a routine basis, but yeah, you know, so it's an artificial construct, and I think everybody understands that at some point that it will go away. Whether it will require payment of a management fee, a more global management fee, or whether it will require full migration to an episode-based reimbursement model, I'm not sure. Actually, the commercial payer is not your problem. Medicare is your problem, right? So Medicare's got this way of doing things, and I think they have a very complex claims payment system and certain expectations. The other thing is that is unquestionably true is that by and large, both Medicare and commercial payers have historically poorly understood what oncologists do. They really do, and so they apply sets of rules that across the spectrum of healthcare, and oncologists are sort of caught in that downdraft. That's an important statement, because if you think you've got administrative expense, claims payment systems are extraordinarily complicated and extraordinarily expensive to upgrade, maintain, or change. And the reason I say that is because as we think about how we want reform to occur in oncology, we need to be sensitive to the fact that oncology is part of a healthcare ecosystem. And the kind of things that we want to change in oncology ought to be at least compatible with what's happening in the world of healthcare as a whole. You know, there are lots of things that insurance companies do that as a provider I thought were just plain stupid, and as a payer I wish I could get rid of. You know, prior authorization is a great example. You know, prior authorization is designed to mitigate risk, right? So it's a way to promote evidence-based treatment. So wouldn't it be better if we had a way that the providers could document that they're doing evidence-based treatment, and then we could just eliminate prior auth? Because I assure you, prior auth is expensive for the health plan. There's cost associated with prior auth, cost from the administration of prior auth, and definitely cost associated with appeals. You hate it, and by and large, the payers don't like it because it is, by and large, a manual process for everybody. So we have experimented, for example, with a system where if you're using one of the Pathways programs, that information is actually transmitted automatically when you enter the treatment plan in the Pathways program, transmitted automatically to the prior auth people, and then it's just done. It's just done. And so instead of multiple steps, it's portal-based, electronic, and happens real time. And honestly, that's a fairly nice incremental improvement. Ultimately, if we do go to a system where payers shift risk to providers, then it becomes less of an issue. But we're a little ways away from that, in my opinion.
What do you think, Jeff?
I think that a lot of what Mike has said is true. I think the real key to being able to move the chains as far as all this goes is to find what oncologists control and what they don't control, and then make them accountable for the things that they can control. You know, ASCO has developed a payment reform proposal that actually has 4 stages, and you could even call it a continuum. One of them is very much like the OCM model. Start with fee-for-service, give additional payments for management fees, and then make people accountable for the costs of the care that they provide in a variety of ways, including value-based pathways. One of the things that we have not been very good at in medicine in general, and I think probably oncology in particular, is we're real good at looking at overall survival, we're really good at looking at toxicities and managing all those kind of things, but we've never said, let's bring value into the equation. Let's determine what this drug really brings to it as far as both quality of care and cost of care. You can do that if you develop value-based pathways. So if you set up and you say, you're going to be accountable for doing these things, and these are things you can control, then you pay us to do those things in a way that isn't fee-for-service, and you let us go. Then you've provided a sphere within which you can innovate.
So I'm glad you said that because it pivots to another thing I want to discuss, but just tell you a little bit about our experience. So we have 120 oncologists now, we're several states, and we've gone into the idea of bundles. And it was interesting. We could not get the 110 oncologists to agree on a specific regimen in the adjuvant setting. They wanted to choose from the list that NCCN or ASCO puts out. But what we did get them to agree to is that we were going to measure total cost of care for the adjuvant therapy, and then the hard outcomes that you need to measure, including incidence, severity, and toxicity, and then have a group of a committee that is our quality committee look at them and look at the data with the payer, and then at the end of a 1-year measurement period, take off regimens that cost more money or induce more toxicity and didn't have a better outcome. And that we got them agree to do, because their argument was, don't show me a JCO paper where you have a select population that isn't my patients, so show me my patients. But I want to